I guess we can get started. Good afternoon, everyone. My name's Rick Adams. For those of you who don't know me, I'm the Director of External Relations here at Dartmouth-Hitchcock, and I've been asked to sort of guide a conversation this afternoon on accountable care and population health and what it means. There's a lot of talk here at Dartmouth-Hitchcock and across the country in where healthcare is going, what it means, what accountable care really means. And so we've pulled together some of our leadership to have a conversation. We have an hour. We have some questions that have been asked by some of our colleagues over the internet. We're not going to take questions here today, but if you have questions, we would invite you, if you're watching on the stream or if you're watching on the archive a little bit later, to submit the questions, as others have done earlier, to answers@hitchcock.org, and we'll try and get the answers back to you. Also, I understand we're live tweeting. We're moving into the social sphere, and the hashtag, Suzanne, is DHACO if you're watching and you want to watch the Twitter, if you want to contribute to the conversation on Twitter. So with that, we'll get going. Let me introduce the panelists. I think you know them all. To your immediate left is Steve LeBlanc. Steve is our Executive Vice President for Strategy and Network Relationships. In the middle, Dr. Barbara Walters, Executive Medical Director, who's been heading up a number of our ACO efforts, and Dr. Gregg Meyer, our Chief Clinical Officer and Executive Vice President for Population Health. So I'll sort of lob out the first question, very general question. Let's define the terms that we're talking about here. Let's talk about population health. And Gregg, maybe if you could start us off by, when we say population health, it means a lot of different things to a lot of people. What does it mean to you?
Sure. So I think when we talk about population health, one of the first things to remind ourselves is that that is what we are really about at Dartmouth-Hitchcock. And if you go back and look at our mission, saying we want to have the healthiest population possible, this has been what we've been about. There's nothing new here, except there is something new here. It's the way we focus our efforts. So when I think about my work as a primary care physician, and I see a patient with diabetes, my job is to get their blood sugar as low as I possibly can safely to prevent them from having complications. In the past, that was my job. But my job's become more than that. Because part of my job now is to think about not just the patient in front of me, but what about the other folks in the community who have elevated blood sugar, who aren't coming in to see us today, but they're going to be coming in to see us in 5 years or 10 years with their heart attack or with their end-stage renal disease, with their kidney failure. So we need to think about how do we open up access, not just seeing people face-to-face, but virtual visits and other means. But population health goes one step further. And that's to recognize that it's not just about the patient in front of us or the patients who are out there not getting care, but it's about the community we serve and those patients of tomorrow. So under population health, it gives us the opportunity not just to think about delivering health care, not just for me to think about prescribing medications and doing tests and sending patients for procedures, but it gives us the opportunity to think about what is it that we can do to keep people safe and healthy, not just now, but moving forward. With population health, it's not just about what we do at Dartmouth-Hitchcock Medical Center or what we do out in our community group practices. All of a sudden, it's important about what we do in our schools. What are we teaching kids about nutrition? What interventions do we have in the community to try to promote exercise? Because you know something? That child who becomes obese, they're the diabetic patient sitting across from me 15 years from now. And they're the one who's out there not getting health care and coming in with their kidney failure or their heart attack. So population health is what we've always done. It's delivering great care to our patients, but it's also looking ahead and saying, how can we serve this community better? Not just working on the delivery of health care, but thinking about prevention, thinking about the social determinants of illness and how we can, as an organization that's vital to this community, to have an impact.
Thank you, Gregg. Barb, that sort of tees up a question for you about how we maintain this population, how we get to preventative measures and things like that. And you've been involved in the Pioneer ACO. You've been involved in some of the commercial contracts that we've been involved. You're also involved in the OneCare Vermont ACO. You're the medical director for that, which is in application with CMS. Hopefully we'll hear soon. But what is an ACO? In its simplest terms, how does it work? Why are we interested in playing?
Great question. If you've seen one ACO, you've seen one ACO. So an accountable care organization, an ACO, is a group of providers. And it can be any form of provider group. It can be a multi-specialty group practice, like Dartmouth-Hitchcock Clinic. It could be a hospital. It could be a hospital who owns a group of providers. It could be an integrated delivery system, providers, a hospital, perhaps one that owns a nursing home or a rehab facility. So it's a group of providers who have decided that they are going to step up and be accountable for cost and quality of the population that Gregg was just talking about, the population for which they, for whom they are taking care of. It's an arrangement of the provider group and the payer. So the payer can be the government, like Medicare. So Medicare is the, in essence, insurer or the payer that Dartmouth-Hitchcock and Mary Hitchcock Memorial Hospital have agreed under the rubric of under the name, the Pioneer Accountable Care Organization, to have an arrangement where Dartmouth-Hitchcock has stepped up and say, we are going to take responsibility for the total cost of care of the patients, the Medicare patients who get the preponderance, who get most of their care from primary care doctors and certain medical specialty doctors who are employed or who get their paychecks from Dartmouth-Hitchcock Clinic, and also have responsibility for providing a certain level of clinical quality for that particular group of patients. So again, if you think back to the mission, vision, and values of Dartmouth-Hitchcock, we have always espoused that we want to provide value. And value is, in fact, cost and quality, an accountable care organization, a group of providers in any kind of configuration who, for the population that they are getting revenue from, whether it's a commercial insurer that they have a contract with, whether it's the government for Medicare patients, whether it's Dartmouth-Hitchcock and Mary Hitchcock as an employer, all of you who get your health insurance from us, not all of you do, but a lot of you do, we have a responsibility for the total cost of care, of health care that you get, and we have also taken responsibility to provide a certain level of quality. And we are transparent, and we will let folks know how we're doing on those quality measures and how we're doing on the total cost of care for those populations that we're providing, that we've decided that we are going to be in an accountable care arrangement with a payer. Does that make sense? Yes? So sometimes the patients don't even know that the provider group has an arrangement that is, in fact, what we in the world are now calling an accountable care organization. Because again, let's talk about the Pioneer ACO for a minute again. The patient can go to any doctor that they want, any place in the country. The ACO doesn't force a patient to go somewhere. Patient has total choice where they go. And Dartmouth-Hitchcock is, in fact, taking responsibility for the total cost of care, no matter where that patient is. So it behooves us to understand, to form really close relationships with those patients so that when they're perhaps a snowbird and move down to Florida for a couple months of the year, we want to know what's going on with them when they're getting their health care needs met down in Florida, because we're responsible for the total cost of care for that patient, no matter where it's delivered. Might not be delivered by us. Again, patient might not know, free choice, but we absolutely believe that this is a very important movement in healthcare revenue realignment so that we're not just getting paid for an acute visit for what we do. We are taking responsibility, like Gregg said, for his diabetic, for the population of diabetics that Dartmouth-Hitchcock takes care of, and for all of the diabetics and their care and where they're getting their touches in the community. That's it.
Steve, that sort of points to something I wanted to ask you. Barb mentioned several times relationships. ACO is one way of delivering care, but when it comes to relationships, talking about the relationships with the commercial payers, with the insurance companies, well, if we talk about OneCare Vermont, we'll be in a relationship with Fletcher Allen and 13 of the 14 hospitals in the state of Vermont. The relationship building that goes on here is nothing new. We've been involved in a number of these over the years. We've got a lot of other things going on as well, don't we?
Absolutely, Rick. And I think they're all of the relationships are really focused around three themes. And those three themes are the population that we're serving. So how can we work with others to improve the health of the population, as Gregg suggested? The second, as Jim has talked quite a bit about, is how do you then, if you can touch that population, either through Dartmouth-Hitchcock being the provider or through our partners that are the providers to those patients, how do you actually get value-based care delivered to that population? So how do you improve the quality piece? And the third is the payment methodology, which Barb has just talked about as the accountable care type. So as we think about the relationships, it's really how can we work with others to serve this population better, improve the overall quality, and then try to transform the payment system away from fee-for-service to something that has more of a population-based effect to it. So think about a medical cost target for a population. We need to work with others to do that. We don't provide at Dartmouth-Hitchcock all the care to that patient. They get their care at APD, they get their care in Vermont, they get their care down in southern New Hampshire. So as patients are engaging throughout the region with other providers, it's really important to try and build those relationships and try and be as coordinated as you can with other providers. So when we talk about relationship building, it's not for the sake of developing a relationship, it's for the sake of trying to achieve those goals, Rick.
The second point you made, Steve, was about the delivery of care. Leads me to a question that came in over the internet from one of our colleagues in the post-anesthesia care unit, the PACU. And the question is, how will this transition affect employees in their day-to-day care of patients and their families? Gregg or Barb, do you want to start that one out?
Sure. So I think the question was, how does it affect employees in their day-to-day care? I think in a number of ways, many, and in another viewpoint, very few. I think what Steve said before is important, is that when you think back to what many folks would label kind of the bad old days of managed care in the 80s and 90s, why was it that America didn't really embrace it? Well, there were three reasons. Number one is there probably wasn't enough money in the system to support it. The second one is that it restricted choice. It said, here's where you have to go. People don't like that. It's an American value. The third was that there was no real gateway to ensure that you got consistently high quality. And so putting on kind of your most black hat in your closet, you could say the way to make money under managed care was to cut back on quality, to skimp. Accountable care is a game changer because it addresses all of those. It tries to fund it adequately by looking at what was historically spent under the fee-for-service system and to carry that forward and then provide rewards retrospectively if you manage to save money. Secondly, in terms of dealing with choice, it allows you a free choice of providers. And then finally, it requires certain quality metrics to be hit. You have to attain a certain level of quality and be able to demonstrate that in order to have access to those shared savings. What does that mean for those of you on the front line? Well, it means that patients are still going to have a choice of provider. So we got to provide great service. We got to make people want to come to Dartmouth-Hitchcock. You know, people worry, patients can go anywhere. They could go to Florida. It's true. And my TDI colleagues taught me that the best fence is a good pasture. We need to make this a great pasture, that people want to come to get their care. So we got to still deliver high quality service. In addition to that, what's going to change is we are going to be more focused on hitting certain quality metrics. So for our colleagues in the post-anesthesia care unit, that work that we do to decrease surgical site infections, to make sure that antibiotics are given appropriately or on time, both before the surgery and discontinued appropriately and on time after surgery, that's important to provide great care for our patients. But by the way, we're going to be measured on that. Not only is it going to appear in the newspaper, but it's also going to show up in terms of us having access to this shared savings or not. And finally, it's going to change some because we are now going to be rewarded for the way that we provide care here traditionally. What do I mean? With all due respect, I don't think Dartmouth-Hitchcock has been entirely successful at the churn and earn of fee-for-service. Why do I say that? I'll give you 2 data points. The first is right down the hallway here. If you walk down the mall, you'll see the Center for Shared Decision Making. The notion is that we're going to help patients make the decision that is right for them about whether or not they should have spine surgery or have their knee replaced or have a hysterectomy. That makes no sense under fee-for-service. Just do the surgery. We'll get paid for it. That's not the way we practice at Dartmouth-Hitchcock. So accountable care is a game changer because we're going to be rewarded for doing the right things and appropriate things for our patients in a way that we couldn't before. And the second data point is when you look at the way that we utilize imaging. Many of you know 6 months ago I came up from Boston. There was no such thing as satiety to the American public's desire to see what the inside of their body looked like. You want a scan? That's great. And we made money on that. I look at the utilization of imaging here at Dartmouth-Hitchcock by my clinical colleagues. It's much lower. Well, that's crazy. Look at all the money we left on the table, all the money that we could have made by ordering those tests. They're not the right thing for the patient. We've been doing the right thing. We haven't been rewarded. So for that person, the post-anesthesia care, we're going to be paying. We need to focus like a laser beam on the service we provide our patients, provide that culture of caring. Number 2, we've got to hit the quality metrics, and they're going to all play a role in it. And I would say, number 3, we are going to be in a position where we're going to be rewarded for doing the right things for our patients and providing Dartmouth-Hitchcock care.
And I'm going to pick up at number 4. Number 4, the post-anesthesia unit is going to communicate as soon as possible with the primary care medical home of the patient for whom they're taking care of, for whom they've performed whatever procedure it was that they did. Because the cornerstone, at least the Dartmouth-Hitchcock cornerstone of an accountable care organization, is in fact a primary care medical home. And a primary care medical home takes responsibility of understanding and working with the patient across helping the patient manage all of those very confusing, complicated transitions of care. Transitions from an ICU to a step-down unit to a regular bed to home with a visiting nurse association. Think of sort of the nurses in the hospital basically doing report out as they transfer from one level of care to another. There hasn't often been that same level of exquisite report out from the discharge from the hospital into the back into the ambulatory care or the primary care setting. So our primary care medical homes have worked diligently to transform the role of the nurse and to transform the role of the primary care provider into a primary care team and have the nurses gain great skills. I've got some of my great care coordinators sitting out there in the corner, where they will work with the discharge planners and then work with the patients in that discharge process where they might still be in pain, they might be worried, they might be anxious at home, and make sure that the patient understands what they're supposed to do when they get home, call them at home, and get them back into their primary care medical home so that anything that's changed can be known and well taken care of and well coordinated.
Greg, you use an analogy as we transition from fee-for-service to the other payment models. You've used the analogy of a foot in 2 canoes. It's not turn one off and get right into the other one. The transition's not insignificant. How do we get from here to there, understanding that we change the way we deliver care, but in terms of funding, how we get reimbursed, what are the challenges we face in the transition?
Sure. So just to follow on that analogy, the analogy is that many of us have had our foot in that fee-for-service canoe, and now there is this new accountable care or shared savings or risk canoe, and those two canoes are pulling apart right now. And I think if you can imagine yourself in that position, you get very uncomfortable very quickly. At some point in time, you have to make a decision. As from when do you jump from one to the other? But you never completely jump from one to the other. We're an academic medical center. We provide very specialized tertiary and quaternary services here. We are doing that now. We'll be doing that in the future. What that means is we always will have some fee-for-service referral business. But we are, because of the way we practice, moving as rapidly as possible into this other canoe, trying to make that transition where we are paid on a risk basis and where taking care of that population is something that we get rewarded for in terms of being able to share in the savings and being able to bask in the glory of that high quality that we obtained and shared publicly, rather than simply going out there and trying to churn and earn. That transition period is going to be uncomfortable. It's going to be a hard time for all of us. Buckle your seatbelts. The reality is that whether or not you're sitting here in Lebanon, New Hampshire, or you're in Baltimore, Maryland, or Salt Lake City, Utah, or Sacramento, California, it's going to be a difficult time for everyone to make that transition. What we've done, as Steve alluded to earlier, is we've made a conscious decision. And that conscious decision is one where we've said, you know something? We believe that the right thing for our patients and our community and our region and our opportunity to be a national model is to move into these risk contracts as quickly as we can. It's not that quick. We have a small fraction of our patients in these arrangements now, but we can see that we need to build the capabilities now to manage well to that because it will grow very, very quickly. We've made a decision to move into that risk canoe quite quickly, and it always reminds me, when I was in the military, I was taught that no decision is a decision, and it's usually a bad one. It's going to be really uncomfortable for us as we make this transition. How are we going to distribute our dollars around the system? How are we going to make sure that physicians and nurses are paid adequately and that we can recruit the best and brightest to be part of a wonderful system here? It's not going to be easy. What I can tell you is it's not going to be easy here, but we're going about it deliberately and thoughtfully. For your colleagues around the country who are just waiting for it to happen, no decision is a decision. It's usually a bad one.
Steve, I want to go back to sort of definition of terms. And Greg, you mentioned risk several times, lives at risk, risk pools, risk contracts. Steve, when we say risk, what do we mean? What kind of risk are we talking about?
So, Rick, like ACOs, you've seen one. There are a variety of different risk models out there. So I'll describe sort of the typical risk model that we have. And it starts out initially, whether you're dealing with Medicare under Pioneer or OneCare Vermont with the Medicare Shared Savings Program, which is a variation from Pioneer, or even with our commercial payers like Anthem, Cigna, or Harvard Pilgrim. The first thing is you look at the patients that we take care of, principally primary care patients, that are in a sense attributed to Dartmouth-Hitchcock. So they've chosen us as their primary care provider. There may be other patients that predominantly see a specialist, and they may get attributed to us. So we end up first identifying, here's the population, and the payer agrees, yep, that's the population, that's yours. Then the payer works with you and says, okay, let's look at the historical costs of those patients over time. And you like to have a large number of patients because the more patients you have, the more you can sort of spread the risk that I'll describe. And so they identify what's called a medical cost target. So what's the total cost of care that was spent on that patient over the past year, maybe 2 years? And then they set a target with you for the following year. And that target gets adjusted either through some inflationary factor, most importantly by an acuity factor. So what's the risk of that patient? And we actually have data that we can verify what the payer does with that, so we can either agree or not agree on the medical cost target and negotiate that. Once that target is set, and sometimes that target includes all of the costs, sometimes it includes a portion of the cost. For instance, they might not include pharmaceuticals, even though that's a large cost. They may say, well, we're not going to hold you responsible for very expensive patients that have a very bad outcome, so maybe they limit the cost per patient but at some point you have a cost target. During the year, we will continue to get paid on a fee-for-service basis. At the end of the year, and we get periodic reports, we'll sort of true up what were the total payments that we received, what were the total expenses for that patient outside of the Dartmouth-Hitchcock system, and how do those match up against that cost target. And there are always quality metrics that are part of that. So we have to meet a certain level of quality metrics. If we meet the quality metrics and the total cost came in under the target, Dartmouth-Hitchcock can share with the payer in that shared savings. So that's a way to get the funding. What's interesting is, let's take a Medicare patient, and in Pioneer we don't include the pharmaceuticals. So the average cost is about $10,000 per year per patient. Well, Dartmouth-Hitchcock only provides maybe 40% of the care for that patient. The other 60% is incurred by doctors that are not part of Dartmouth-Hitchcock. Maybe it's Concord Hospital, maybe it's Southern New Hampshire Medical Center, maybe it's critical access hospitals around us. But we're held to that total target. But if we can influence the care, preventive measures, care coordination, looking at gaps in care and making sure those patients, and we can lower that total 10,000 to say 9,000, we can get a share of those dollars that are dollars that we couldn't access if we were just looking at the care that we provided. So there's a large opportunity for us to be able to then take those dollars that we share and reinvest back into the organization for the other things that we need to do. And it gives you the flexibility to be able to put in place certain things that otherwise aren't paid for under fee-for-service. So we could have nurses going out to the homes of patients. We could provide home monitoring equipment to patients. We could actually spend that money in ways that further help control the overall cost and improve the quality. So on the risk side, there is really two models. One is that shared savings, where if you beat it, you get some. There's also two-way risk, which means we may be liable to pay back the payer if we spend well over the cost target. And so what we've tried to do organizationally, because we recognize the two-canoe issue that we have, is try to limit those corridors of risk so that we were easing into it, and we don't want to take on too much risk too early as an organization. So we're trying to get ourselves ready to take more and more risk as we're able to manage it.
Now, there's been some talk, you talk about the risk up and down, with the OneCare Vermont ACO, which we have not gotten the approval from CMS, but it's in process right now. There's a lot of talk in Vermont about the initial application being seen as a for-profit. We're a not-for-profit organization. Fletcher Allen is the same. Are we moving to for-profit with OneCare, with some of these ACOs, or is that simply more of the application process rolling out legally the way it did?
Yeah, I think there was it really had to do with the application process. What Dartmouth-Hitchcock and Fletcher Allen together agreed that we would create an accountable care organization for Vermont. And we were doing this really in consultation with the state of Vermont, the Green Mountain Care Board, which was very supportive of this concept. What we established, the structure was a limited liability corporation, which is a very common structure. And it's essentially a pass-through organization, so it takes on the characteristics of its owners, and the two owners are not-for-profit. So we essentially operated as a not-for-profit. The confusion came in when an application had to be submitted to Medicare. And Medicare had two blocks to check off. You were either for-profit or not-for-profit. And because of Vermont law, the way the board had to be established to meet Medicare rules didn't really qualify with the laws in Vermont of what the board had to look like to be a not-for-profit. So it was, because it couldn't be not-for-profit, the decision was to check the for-profit box on the application. But OneCare operates as a not-for-profit.
Thank you for clarifying.
Is that clear as mud?
Clear as mud. Lawyers make it that way.
That points out how complex this all is.
Well, another way to think about it is Medicare will contract with the ACO, and then the network participants throughout Vermont will get paid fee for service. If there is some shared savings, it will come back to the ACO, and the ACO will distribute 90% of that savings out to the network participants. So think of Mount Scottney Hospital and its physicians, some private physicians that are included in that, Southwest Vermont, et cetera. As you said, 13 of the 14 hospitals, 2 FQ8Cs that are involved. OneCare will only retain about 10% of the shared savings, only to offset costs that are in the OneCare infrastructure, which is really data support, care, more centralized care management where that's necessary. So there's no profits being retained at the OneCare level.
Barb, yeah, go
Before you
ahead.
go, because I do want to follow up on something you said, because it sounds awfully complicated. And I think if you sit there and you listen, you hear ACO and SSP, it gets really complicated really quickly. But I think you have to remember what it is that we're about. And we could be operating in a fee-for-service system. We could be operating in a place where we're taking 100% risk, like the old-fashioned managed care or someplace in between. No matter what we do, no matter how we're getting paid, at the end of the day, if we take great care of patients, we do it in a patient-centered way with a culture of caring, and we do it efficiently, no matter how we get paid, we win. So it's really complicated.
Mm-hmm.
What we need to do is what we've always tried to do, and more so. We need to provide great value.
Well, Barb, I've heard you say in a couple of interviews, if we do this well, it should be entirely transparent to the patient. They shouldn't really know because they should get that same level of care. But when patients do this, because of all the talk about ACO and relationships and collaborations, is there a way to explain to the patients, that what they're getting is the best care in the right place, the right time, every time?
I think the key cornerstone of an accountable care organization is the relationship that the patient has with every person that they touch in the organization. And that if a patient feels known, welcomed, isn't asked by 6 people in one visit, are you a smoker? If they begin to feel as if we've got their back, we've got their front, we have their information, and that we provide outreach even when they're not reaching out to us, that they get it, and it feels different, and their experience is substantively different when it used to be them trying to play telephone tag after a visit that felt short, was not particularly satisfactory, where the nurse had to call them 6 times, couldn't leave messages because that's a HIPAA violation. So for 3 days, they're desperately trying to get the information that they need to be able to manage their care. So if they feel that they are partners with us, that's more important than me being able to explain to them what accountable care is. I can use the words. I can use the words that I've used with the folks in here. And I think they would understand that. But until they feel it, and until they feel welcomed, till they feel the access, till they feel known by us, until they feel that we are helping them navigate a very complex system, I think that's the key differentiating factor that Dartmouth-Hitchcock should and could and can and will be able to be successful at. That patients will be able to say, you know what? They are accountable. They care about me. They care about me clinically, and when I need to be somewhere, I get there. And if I don't need to be somewhere, they explain to me why, and I understand it, and I have a relationship with them that is such that I believe them.
Do we worry, though, that as we build these relationships, as we expand out, that we are the largest employer in the Upper Valley, we're the largest healthcare organization in the state, but compared to the organizations that we consider our peers, we're a relatively small organization. Do we worry that with all of this relationship, we make it too big and sort of kind of lose track of that traditional obligation we felt to our patients and to the communities that we serve here in the Upper Valley?
I would say, there is a scale issue to much of this. There are a couple of things that are going to be huge enablers that are going to allow us to really thrive in this new environment. One of them is being facile with data, is to understand what's going on with our patients, to be able to anticipate their needs, to be able to manage their care. For a primary care doctor like me to be able to review a list and say, here are the 40 patients with diabetes, these 3 didn't get their tests, how do we get them in here? That requires, to get that kind of a system together, it requires a certain amount of scale. Because the reality is that the small hospitals sprinkled throughout northern New England, they're not going to be able to afford something like that. So there is going to be a pulling together. Some of it's going to be very formal in the way that we work with some of our sister institutions. Others are going to be new, the way that we're going to be working together with Fletcher Allen, but they are all going to be, in many ways, creating a greater and wider network. Some of it very tightly held, those patients who we take care of here. Some of it more loosely held, those patients who we influence through our relationship with, for example, Fletcher Allen. But we will be networking to become and look larger. With that said, the reality is that we still need to focus on delivering terrific care here and at all of our sites and not let the size overwhelm us. When I think about my experiences I've had in the past with large teaching hospitals, that much of their day is spent what I call feeding the beast. It's doing the work to just pay for the infrastructure to keep that huge place with all that glass and all that steel going and keeping those elevators running up and down 20 floors. That, feeding that beast is a huge ball and chain. It's going to prevent them from being nimble in this new environment. So our strategy of, yes, we're trying to develop relationships, we're trying to become quote unquote larger, but we're not doing it by making Dartmouth-Hitchcock the green giant that swallowed up northern New England. We're doing it by creatively working with our community partners in ways that we think bring value not just to us, but to them, and most importantly, that it serves the community, that it provides the people in our region with the health care that they need. It's a different strategy.
Mm-hmm. Steve, as we talk about sort of these collaborations and ACO models and all that, what kinds of regulatory or legal considerations are involved? Or is it simply just continuing to do things the way we've done them, just on a different scale and model?
Well, I don't think that, we have plenty of regulations to deal with as it is, and they don't substantively change under an ACO model. So from that standpoint, I wouldn't say there are anything of concern. As you start to work together with other providers, you just want to make sure you're doing that in the appropriate way. But moving from the fee-for-service into the world of ACO, there's no real substantive barriers that you have to deal with or new obligations that we have. We have the existing ones.
Another sort of on the ground question, Barb. We've seen talk about care coordinators, and it seems like they're the boots on the ground when we talk about ACO, particularly with Pioneer. We've got a couple of great examples that we've seen, but talk about the role of the care coordinator and how that sort of evolves over time, and how, if it's different from what we've done, how it's different or how it's more the same.
Well, I feel like I should call on the care coordinators to do this, but I will try, and they can keep me honest and jump up and down or give me thumbs up or thumbs down when I'm done here, because they're all staring at me right now. Yeah, there they are. So a care coordinator is a very skilled person, in general, a nurse, sometimes a social worker, usually an RN, could be an LPN, could be a psychologist, I suppose, who works as part of a team, a care delivery team. At Dartmouth-Hitchcock, in our accountable care organizations, we have them primarily embedded right in primary care teams. There are certain care coordinators who work in specialty care departments who are very good at very complicated disease management, but I'm going to put that kind of care manager, care coordinator aside and talk about the care coordinator who has a special sort of heart and skill set where they are trained in motivational interviewing, understand the Prochaska levels of change. So everybody in their life is at some level of willing to make a change about something. Think about something that in your life you could do better. This week you might really want to, well, it's Thanksgiving, so perhaps food is on everyone's mind, and you want to make sure that you are eating nutritiously so that you can have your one day of really eating non-nutritiously. So understanding sort of at what point each person is and their willingness to change their healthcare behavior and habits that have something to do with their healthcare. They also have really good medical and content knowledge on the diseases that people have when they come in to see a primary care doc. So that if we have a brand new diabetic, I have my brand new diabetic here, and I have my very complicated diabetic over here. So with my brand new diabetic, well, I know Steve better than I know Gregg, so I feel safer. I feel safer making Steve the sickie over here than I do Gregg. So with our new diabetic, as he's first diagnosed, he has a certain set of questions and worries and concerns that he needs to get baseline education about and really learn to manage his illness. And the care coordinator will work with him and help him as he learns to manage his disease, and work with his family or anyone else that he brings in that he wants to understand it on his behalf. Sort of my complicated diabetic over here, who now is at the moment when he really wants to take control of his life and manage his diabetes better, but has other things that have happened because he hasn't been at that particular change in his life. Perhaps also has problems with his eyes and problems with his circulation. So he has to also see a bunch of other docs besides his primary care doc. He's got to see his ophthalmologist. He's got to see whoever his vascular surgeon, because and his podiatrist, because he's not getting really good circulation to his feet. So the care coordinator really understands that those are all of the things that happen with someone with diabetes, and helps Steve and, again, his family, or just Steve, work through and connect and coordinate the care, all of the care, with those other docs that he needs to be able to manage his disease as well. So it really is, and then they have this big magic spreadsheet in the sky. They're called registries. And we have been so lucky. We have absolutely phenomenal data people at Dartmouth-Hitchcock. So thank whoever it was in 1980 or the early 80s who set up our data warehouse, because we have bits and bytes of data that are clinical data, billing data, claims data, that we are able to organize in such a way that we can get a snapshot of a patient that sort of that lets us know from a clinical perspective kind of the things that you would want to know about someone from what they need to do from a prevention perspective, kind of how their general health is, if they have any comorbidities, if they have a major chronic disease, and the last time that we saw them. So our care coordinators, in their spare time, when they've already taken care of Gregg and Steve, And I think resources is a big issue for accountable care organizations. They can look at this big spreadsheet in the sky, and they're going to call Peter, who I've known a long time too, because Peter hasn't been in here for a long time. And they happen to know that Peter also has diabetes, and he needs to get in here because his last blood level was not what it needed to be. So they'll call him and they'll say, Peter, you know, what's going on? We noticed that you're about 2 months late for whatever it is that we need you to do. Come on in. And they'll work with him to judge where he is, if he's willing to come in and if he's willing to take control of his particular disease. So that's kind of the day in the life of a care coordinator. They are key cornerstones of making this whole thing work, talking to other docs, helping people transition from hospital, inpatient, outpatient, helping new patients, and then trying to do outreach as well. So did I do okay, guys? Yes? All right, thank you.
That would be a thumbs up. Yeah. Greg, I want to go back to the two canoes discussion. One of the pioneer is about primary care. There's a focus on preventive medicine, keeping people out of the hospital. But for those providers who are expected to provide a certain level of RVU, that looks like it would be a contradiction. And as we go forward, how do we resolve that?
In many ways, it is. And the challenge here, again, is navigating between these two worlds and making the transition. For better or for worse, the RVU, the relative value unit, it's a measure of work. It's the most convenient and most accepted way we have to measure productivity. We all need to be productive. Now, as we move into this new model, though, how we define that is going to change. Right now, we're measured pretty much straight up. If I see a patient in the clinic that generates a certain number of RVUs, if a surgeon does a procedure, that generates a certain number of RVUs, and those are tallied up. One of the things that we're going to have to do during this transition is to try to figure out how do we put a value, because the RVU is no longer the convenient coin of the realm, on the other important work to come. For example, I can envision in a time in the not so distant future when the majority of the way that I interact with patients isn't face-to-face down at Heater Road, it's over their phone, or it's through Skype. Many of you have kids off in college. Skype brings you close to home. How come we don't do medical visits via Skype? The technology works. I'll tell you why. Because up until now, under fee-for-service, by and large, most providers in America didn't get paid for it. Well, as we move to accountable care, it opens up opportunities to start to value that non-face-to-face care. We will, over time, be migrating away from the RVU as the single measure of productivity. For someone like me, it may be how many patients do I take care of? How big is my panel? And after you adjust it for risk, that maybe my patients are more or less sick than somebody else's, so we'll adjust for that. That how many people am I taking care of compared to somebody else? That may be the right measure for me. For a surgeon who's seeing referrals from the community who does very specialized care, the RVU may still remain the best and most convenient measure. So I think we're going to be moving into a very hybrid world where we're going to move away from a single way of measuring our productivity to multiple ways which recognize that there are going to be different ways that we deliver care. Some will stay the same, some are going to be very different.
We have a few minutes left, and one of the things I want to wrap up, and I'll ask this of all three of you. What are 2 or 3 things that we, as professionals within a transforming healthcare organization, need to know about the future of healthcare delivery as we go forward? If there's a couple of takeaways that we would get from, there's a lot of information here, but a couple of takeaways for all of us as we go forward and advance the mission of DH.
I'm happy to go first. And I would say we need to get good at a few things that can get very confusing, again, as we think about the alphabet soup of ACO and SSP, and it gets very confusing very quickly for most of us. But actually, if we focus on just about 4 things, we'll do pretty well. One of them is we need to figure out how to get those patients who aren't currently engaged in care to get them in to see us. How do we get those patients who have an elevated blood sugar that are a time bomb out there in the community, how do we get them plugged in? The second thing we need to do, which Barb talked about, is we need to coordinate care. Many of you have had the experience of having a parent or an elderly relative look to you as the, quote, healthcare person in the family to help coordinate the care. What a nightmare. That's really hard. I find that I've got a pretty stressful job in a number of ways, but there's nothing as stressful as trying to coordinate the care of parents and grandparents. It's really difficult. We need to learn how to coordinate that care and how we can take a role in working with patients and their families, because we know that there's a lot of savings and good value, quality to come from that. The third thing that we need to be able to do is we need to be able to reintegrate mental health and oral health, two things that were carved away from healthcare during the 1990s and the last decade as well, and pull them back into healthcare to make it easy for patients to access those services. It's been very difficult for many of us to access those services for our patients or even for our own families when they needed them. We need to break down those barriers and pull them back into the family. And the fourth thing we need to do is we need to provide excellent end-of-life care. Excellent end-of-life care. All of us want a good life. Some of us will be fortunate enough to get it. We will all, unfortunately, come to a point in time when we will crave a good death, much more than we ever craved a good life. And in America right now, far fewer get that. We can do something about that. We can do something. We can work with our communities to ensure that people have their durable power of attorney. We can make sure that people understand there are options other than rescue care. We can make sure that we develop systems that allow patients to stay at home and be with loved ones at that time rather than to spend time here in the hospital. All of four of those things vastly improve quality, and the evidence shows that they really save costs. That's what we need to get good at.
Thank you, Greg. Barb?
It's not fair that Greg got to go first because he stole 3 of my 4. So I'm going to have to keep going. So I will add on substance abuse to mental health. That may go without saying, but I think it needs to be called out as well, that we need to reintegrate substance abuse in the continuum of care as well. I think that we need to continue to support and design the infrastructure that makes it easy for all of the docs, nurses, and care deliverers to do the right thing. Because this is about having the supportive systems around us to let every person do what they want to do, which is practice whatever it is that they do to the highest level of quality that they can do it. And it's our job to make sure that they have the resources that we can provide so that they can do it. And we need to keep laser-like focus on this is, in fact, job one. As soon as we get seduced or distracted by the next initiative or think that we have this under control, we realize that we don't. So absolute and utter focus. I do want to say that we have a leg up, that people who choose to practice in a multi-specialty group practice in an integrated delivery system have already taken that first step in saying that collaboration and collegial care is a value that they're interested in, and we need to continue to nurture that and make sure that we pay attention to that. And that includes not just the docs, that includes the teams around the docs as well.
I'll just add 2 other items that I think are supportive of what Greg and Barb said. One is we really need the data to be able to understand where and when to take action and engage patients, which is a big investment on the part of the organization. And we're doing that really in partnership with Maine Health and Eastern Maine and TDI, another partnership that we're working through, so that getting that data to the people on the caregivers to be able to help them make those decisions and be informed about their patients in a much more effective way. And the second is, and Greg mentioned it, it's this idea of telemedicine, telehealth. As we move towards a different payment model, we actually will have the ability to do things in more cost-effective ways and get paid for them. Sometimes we don't do things as cost-effectively because there's no way of getting paid for that, and we can't afford it. This will free us up to do that. So as we move from fee-for-service into these new models, I think it gives us a lot more opportunity and flexibility to do the right thing. And it's more consistent with the culture and the way we've given care over the years, as Gregg mentioned before. So, you know, I'm actually really excited about where we're heading as an organization. And when I think about these new payment models, I think of it less of how are we adapting to the new payment models, but rather being appreciative that these new payment models are really more reflective of the way we think care ought to be provided and have historically tried to do it.
Thank you all. Gregg, Barb, Steve, thank you. I hope this has been helpful for you. A reminder that this will be available on the internet and our intranet site soon. And if you have questions you want to ask, if those of you watching on the stream or watching this on the archive later, send questions to answers@hitchcock.org, and we'll try and get back to you as soon as we can. So thanks for taking an hour and coming out, and happy Thanksgiving, everybody.
Thank you, Rick. Thank you.